Thank you to Dr. Silva and the rest of the committee for having me today. I am not Dr. Belfort, but Dr. Belfort did train me, and so here we go. I'm going to be talking about preeclampsia complications today, one of my areas of interest and focus for research. So I've outlined a few objectives for us to cover today. It's a fairly brief talk, so I want to focus on a few of things in the sort of broader spectrum of preeclampsia. So first, I'll start by defining preeclampsia, and that's with and without severe features, just to make sure that we sort of are on the same page and speaking the same language there. Next, I'll identify complications of preeclampsia and diseases related to preeclampsia. And then finally, we'll spend some time on the management of specific complications. So I think we are all familiar with the fact that preeclampsia is a major cause of morbidity and mortality in pregnancy. So I won't spend too much time on this, but I did want to just point out this one statistic from the World Health Organization that these 5 complications listed here, which do include preeclampsia and eclampsia, account for 3/4 or 75% of maternal deaths worldwide. And as we know, preeclampsia and eclampsia not only a cause for maternal issues, but also a major cause for premature delivery, which results in neonatal issues, including various morbidities and mortalities. So like I said, this is the preeclampsia definition that we follow from the American College of OBGYN. And there may be some slight variations of this diagnostic criteria across different organizations and across the globe, but I think the principles are largely more similar than they are different. So preeclampsia is defined as the presence of elevated blood pressure. So that's systolic blood pressure 140 or more, or diastolic pressure 90 or more. And again, that's 4 hours apart and after 20 weeks gestation. What we call severe range blood pressure would be 160 or 110. And then not only the presence of hypertension, but then one of several other diagnostic criteria must be met. So historically, proteinuria was required, so approximately 300 milligrams or more in 24 hours. More recently, we've started to utilize what we a spot check of proteinuria, so the protein creatinine ratio of 0.3 or more. And then historically, although preeclampsia we defined as the presence of hypertension and proteinuria, we in recent years, or we meaning America, have altered the diagnostic criteria to, in the absence of proteinuria, to include one of several indications of end organ damage, as you all are familiar with. So that would be thrombocytopenia, renal insufficiency, impaired liver function, or pulmonary edema. So that's what I've included over here on the right. So it's the so-called severe features of preeclampsia. So if the patient has any of those severe blood pressure, evidence of end organ damage, symptomatology like refractory headaches or right upper quadrant pain, visual disturbances, and those patients would be categorized as preeclampsia with severe features. And those are really the group of patients that we can see complications, sometimes necessitating admission to the intensive care unit. So in terms of related diseases, and so I consider these all on the spectrum of preeclampsia, with eclampsia being, as you know, new onset tonic-clonic seizures in the absence of other causative conditions, like, for example, underlying epilepsy, HELP syndrome, so the triad of hemolysis, elevated liver enzymes and low platelets, all three of which must be present and demonstrated to make that diagnosis. And then hypertensive encephalopathy, and there's various terms for this. One is PRES, or posterior reversible encephalopathy syndrome, which are more specific neurological manifestations related specifically to the hypertensive process in the brain. And so I consider these all sort of diseases that are related to preeclampsia and perhaps on the more severe end of the preeclampsia spectrum. And we won't have time to go into all of these in detail, but I will talk more about eclampsia later in the talk. So when we talk about complications of preeclampsia, like I said, I like to frame this as sort of end organ damage. And so we'll start with the lungs. And one of the most common complications that we see is pulmonary edema. Acute kidney injury is not uncommon, and we'll go into that in more detail. Coagulopathy and maybe even disseminated intravascular coagulation, or DIC, that can be present with placental abruption or in the setting of postpartum hemorrhage. Neurological manifestations like stroke, typically hemorrhagic stroke. And then liver failure or even liver hemorrhage that can be in the form of either a subcapsular hematoma or even frank liver rupture that has been reported in cases of preeclampsia. So as you can see, all of these are relatively serious complications that can be life-threatening. And so for today, we'll spend most of our time on two of the more common complications, so pulmonary edema and acute kidney injury. So before we get into that, so we talked about the diagnostic criteria for preeclampsia. So it's important to sort of review how to initially assess these patients and to make the diagnosis so that we can perform closer monitoring to stay ahead of or potentially even prevent some of these complications. So as in everything in medicine, a good assessment always starts with a thorough history and physical exam. But when a woman presents, for example, with hypertension, which oftentimes can be asymptomatic, some of the routine laboratory studies that we'll get are complete blood count, complete metabolic profile, and LDH, or lactated dehydrogenase. And that may be different where you practice. That's just the measure that we tend to use to look for hemolysis. Certainly a peripheral blood smear or other studies would be reasonable, but we find that the lactate dehydrogenase for us, the LDH, is fairly easy to obtain and returns quickly with that result. So again, on those, we're looking for anemia, hemolysis, thrombocytopenia. We're also looking at renal function via creatinine, BUN, electrolytes, and then liver transaminitis as well with the AST, ALT. And then, of course, some measure of proteinuria, which I think probably varies by institution. The use of just a single dipstick urine is somewhat discouraged if other options are available. However, in some practice settings, that may be all that is available. So, and like I said, we tend to get a protein creatinine ratio right off the bat. And then depending on the result of that and the overall clinical picture, we might follow that with the gold standard 24-hour timed urine protein. And then finally, some sort of fetal assessment. And that could be determined by the clinician and gestational age, but certainly some sort of fetal monitoring is part of the initial assessment, and with the placenta being one of the end organs, of course. Okay, so complications of preeclampsia. So one of the things that I mentioned is stroke. And so, when the patient typically arrives into our triage area or from another hospital, it's not uncommon that they will be hypertensive and in what we call the severe range, as we talked about earlier. And so we have, goals and guidelines set to really diagnose that level of hypertension and to treat it promptly. And I wanted to start off with just, at least to my knowledge, what we base that on, the severe range blood pressure 160 or 110, is on a small case series from the state of Mississippi here in the US that looked at 28 women who had a stroke in the peripartum period. And what they found was, and of course that's a small number of women, but that's because fortunately this is an uncommon outcome. But what they found is that 96% of women who had a measured blood pressure immediately before the stroke did have a systolic that was greater than 160. So I just like to put that in there just to kind of remind people for the basis for why we, really target that number and aggressively treat those patients as soon as we can. And in terms of what we use to treat those blood pressures, our first line agents tend to be IV labetalol or IV hydralazine, and oral nifedipine is also a viable option that we use not uncommonly, particularly in patients who don't have intravenous access or who are bradycardic, for example. And then for refractory cases, so if we've given several doses of these first line agents, several one-time doses, and are still having an issue with blood pressure control, we tend to use an icardipine infusion, which is a calcium channel blocker. And less commonly, we use a labetalol or beta blocker infusion. And I just put a reminder here in this last bullet point that there is a theoretical, but could be very real chance of neuromuscular blockade and profound hypotension with the use of concurrent magnesium sulfate and calcium channel blockers. So I say theoretical. I personally haven't had this experience, but it's certainly physiologically possible and has been reported. So just something to keep in mind, but not necessarily an absolute contraindication to using those medications together. And then here I've just given a little bit more detail about the acute antihypertensive therapy regimens that we use. And this is we've developed institutional protocols that are very similar to what ACOG has published, and likely many of you may be using with specific doses and intervals for repeating those doses for the 3 medications that I've mentioned. All right, so let's talk a little bit more about magnesium sulfate. So magnesium sulfate is absolutely the drug of choice for maternal seizure, not only prophylaxis, but treatment. And we have good level 1 data to support magnesium as the drug of choice in this specific situation. And so I included the reference to the MAGPIE trial that was published in 2002 in the Lancet, but basically this was a randomized controlled trial of more than 10,000 women across 33 countries. And what they found was that magnesium sulfate reduced seizures in women with preeclampsia by 58%. And you can see there the 0.8% versus 1.9%, that's placebo versus magnesium, and that was statistically significant. And so there are also other studies that looked at comparing magnesium for effectiveness with other types of medications like benzodiazepines or phenytoin, and those head-to-head randomized controlled trials showed that magnesium was superior. However, there are circumstances, although not commonly, where a second-line agent may be indicated. And so second-line agents would include things like benzodiazepines, one-time doses of lorazepam or midazolam, common anti-seizure medications like levetiracetam. And then in refractory cases, when most likely the patient would be in status epilepticus or in the intensive care unit, we can use infusions of medication, most commonly medications like propofol. And so I wanted to spend a little bit of time about magnesium on magnesium sulfate because it is so commonly used and can lead to some real complications and is a high-risk medication. So I just wanted to review and spend a little bit of time on this drug, which I find fascinating. But so there are multiple hypotheses for the mechanism of action of magnesium sulfate. However, all of them are really related in that they all involve the thought that magnesium stabilizes the membranes and thus raise the seizure threshold. But how exactly that is accomplished, no one has really proven for sure. But some of those theories include action at the NMDA receptor blockade, non-specific calcium channel blockade, decreased acetylcholine, vasodilation of the cerebral vessels, thus reducing cerebral barotrauma. So there's lots of theories out there, but none that's really clearly delineated the mechanism of action. Nonetheless, we dose magnesium typically with a bolus, 4 to 6 grams, followed by a 2 gram per hour maintenance infusion. And I just noted there that in the setting of renal insufficiency, just to be mindful to decrease the rate by half to 1 gram per hour and or check serial magnesium levels as these patients are at increased risk for magnesium toxicity since magnesium is renally excreted. And so adverse effects, as I'm sure you've all experienced with your patients, are not uncommon. So adverse effects would include the things like flushing, feeling nauseated, feeling woozy, maybe even vomiting, just not feeling well, as most patients don't on this medication. And then the goal range is 4.8 to 8.4 milligrams per deciliter. And so in terms of toxicity, this table here lists the, in different units, but the serum magnesium and the level at which we could expect different toxicities. So the therapeutic range, again, in the 5.9. And then once we get above 9, we may see the loss of patellar reflexes. So I like to just remind the residents when they're having to do their Q1 hour, Q2 hour magnesium checks that this is sort of a reminder and rationale for what we're looking for and that it is very important. Anyway, levels greater than 12, you might see respiratory depression, respiratory paralysis, and then at very high levels, it could even result in cardiac arrest. And so if there is evidence of magnesium toxicity, then the antidote to give would be calcium gluconate, 2 grams, and that's generally mixed as a 10% solution. All right, so before we talk about a few of the more common complications in more detail, one big kind of overriding issue with preeclampsia and preventing complications of preeclampsia is being very mindful and about fluid management. So it's really critical to get the fluid balance right in preeclamptics, but also very difficult to achieve. So definitely an indication for strict in and out. We call it strict ins and outs, or recording of everything the patient is getting and everything the patient is putting out per hour, to avoid both hypovolemia and hypervolemia. So hypovolemia could be problematic in that this could lead to decreased organ perfusion, specifically the kidneys. Hypervolemia and the excess use of IV fluids can obviously lead to the opposite problem, things like pulmonary edema. So the one thing sort of working in our advantage with these patients is that, and that's what these last two bullet points get to, is that while they may be hypertensive, which would increase afterload, typically the heart, the ventricular function is preserved in these patients. So even though their fluid management can be difficult, I guess that's sort of to say it could be worse, because their cardiac function is usually preserved. And so one less thing to sort of think about there. All right, so let's talk a little bit about acute kidney injury. We call it, previously called acute renal insufficiency or acute renal failure. Those are really all the same thing, but preeclampsia is one of the most common causes of acute kidney injury in pregnancy. And I've included here in the table to the right just one of many diagnostic criteria for the diagnosis of acute kidney injury, which basically breaks it down into stages 1 to 3. And that's just based on the level of rise in the serum creatinine, whether it's 2 times above the baseline or less than 2 times above the baseline. And then the specifics of the urine output, and whether that's been ongoing for 6 to 12 hours or greater than 12 hours. So I won't review that completely, but that's basically for non-pregnant adults, though. We tend to sort of simplify it for, at least for our diagnostic criteria for preeclampsia, to a creatinine greater than 1.1 milligrams per deciliter, or a doubling from a baseline or previous creatinine if that information is available. But just, I did want to put this in to just remind that a normal urine output is 0.5 milliliters per kilogram per hour. So anything less than that should, alert the clinician that there may be a problem with either volume status or kidney function. And acute kidney injury in preeclampsia is often multifactorial. So there are renal changes that are characteristic of preeclampsia that predispose to this. So that would be endothelial cell swelling and injury as a result of the preeclampsia disease process. And also, as you all know, while the patient may appear edematous and even have pulmonary edema, they could be intravascularly depleted because of reduced colloid oncotic pressure. So that protein pressure that generally tends to bring fluid into the vascular system is reduced, and also leaky or increased capillary permeability, so leaky capillaries, that cause a lot of the fluid that we give the patient to sort of leak out. The kidney injury that we see in preeclampsia is typically a pre-renal etiology. So, and that can be determined by calculating things like fractional excretion of sodium. It could also be acute tubular necrosis from renal ischemia. So those things don't necessarily need to be paired out, but just to point out that those are the two kind of most common etiologies of the renal failure. And there are ways through tests like the fractional excretion of sodium to really delineate those two etiologies, in addition to looking at microscopy of the urine to look for CAS. And then just a little reminder there that the acute kidney injury and the buildup of things like BUN can contribute to coagulopathy in these patients who may already be predisposed to it, and can contribute to um, coagulopathy and bleeding that could, further complicate the situation. Fortunately, acute kidney injury only complicates about 15% of cases of preeclampsia, and it's even more common in the context of HELP syndrome. And a very, very small minority require dialysis. And typically the management of acute kidney injury is with conservative measures like I mentioned, just managing fluid balance, making sure the patient's not either volume depleted or volume overloaded, and maintenance of good blood flow to the kidneys so that they can function maximally. And then avoidance of any medications that may worsen kidney function. Some of the more common examples of that would be like nonsteroidal anti-inflammatory drugs, antibiotics like vancomycin, things like that. Okay, pulmonary edema. So this is the other complication that I want to spend a little bit more time on, because we see this fairly commonly, and it's probably the most common reason for a preeclamptic patients who require intensive care unit level of care. So pulmonary edema is the leading cause of death in eclamptic patients. And pulmonary edema, I think important to know that it can be cardiogenic versus non-cardiogenic. So we think of pulmonary edema, and then this is a typical chest x-ray here with these white arrows showing classic signs of pulmonary edema on x-ray. So this is called a curly B line here with the sort of upstroking, sometimes laterally stroking hyperechoic areas. And then what I was getting back to what I was saying, so pulmonary edema can be non-cardiogenic in that, like I said, as in most preeclamptic patients, the cardiac output is actually, or the cardiac function is normal, as is their pulmonary capillary wedge pressure. That's what that stands for there. Although classically we think of heart failure causing pulmonary edema in our patients, in preeclamptic patients, it's typically non-cardiogenic pulmonary edema. And if you see something flashing through the screen, that is my cat. Apologies for that. So the pulmonary edema in preeclampsia, just like with acute kidney injury, is multifactorial, but some of the same sort of physiologic process, and that is that decreased oncotic pressure within the vessels that'll withhold the fluid and the capillary leak that really make it hard to maintain a good intravascular volume without overloading the patient. And oftentimes pulmonary edema can be, sort of categorized as iatrogenic, meaning that we gave the patient excess fluid that they weren't necessarily able to handle, perhaps because of some kidney dysfunction that leads to pulmonary edema. And so I showed a chest x-ray typical of pulmonary edema, but I just wanted to point out that many of us, particularly in the ICU, are very much in favor of and using more and more point of care ultrasound. And you guys may be using that in your labor and delivery unit, and anesthesiologists, I know, utilize this in their practice. But this is just to show that on the right side here is a ultrasound of the lung showing signs of pulmonary edema. So on the, I'll start on the left, but this is a ultrasound of the lung parenchyma, and this is showing like the pleural line. And then what they're pointing out here is what we call A lines. So just reverberations of the pleural line. So this is basically a normal lung ultrasound that doesn't show any fluid. However, on the right, these sort of bright white echogenic vertical lines, or what we call B lines. And if present in large numbers, can help diagnose pulmonary edema and sort of serve as an adjunct or maybe even a replacement for chest X-ray in these cases. So how do we treat pulmonary edema? The treatment for pulmonary edema in preeclampsia is generally supportive. If the patient is hypoxic, supplementary oxygen should be provided. And some rare cases, positive pressure ventilation or even intubation and mechanical ventilation may be needed. And as you know, the medication treatment of choice is to diurese the patient. So they use diuretics like furosemide to help them urinate and clear some of that excess fluid. And I know I don't have much time, so I'll try to, I have a section here about hemodynamic assessment preeclampsia. So I'll try to run through that quickly and some of the additional modalities that we can use to really make sure we know the exact status of the patient and not only their blood pressures, but their fluid status. So historically, pulmonary artery catheters, which are inserted typically through the internal jugular vein into the heart and into the pulmonary artery, were used to more directly measure things like pulmonary artery pressure, central venous pressure, pulmonary capillary wedge pressure. But evidence really didn't bear out that these devices improve patient outcomes, and they're quite invasive. So those are, we use pulmonary artery catheters very rarely as outside of the context of cardiothoracic surgery patients. But every now and then there are patients that have multiple things going on, maybe multiple different types of shock, including cardiogenic, and maybe more difficult, that this is definitely still of some utility. Less invasive options for monitoring hemodynamics would be things like arterial pressure waveform analysis that does require an arterial line, but can calculate cardiac output, cardiac index, stroke volume variation, things like that, simply with the use of this technology and the presence of an arterial line. So this is something that we use often. I wonder if you guys use anything like this in your practice. And then, as I mentioned, point of care ultrasound has really taken off across specialties. And so we use point of care echo to sometimes just generally assess cardiac function or volume status, particularly as an initial assessment, maybe perhaps while we're waiting a formal echo to just kind of get an idea with what's going on with the patient. And on the right here, there are some series published that looked at echocardiographic findings of patients with preeclampsia with severe features. And although, again, a minority of them have pathologic findings, some of the things that you might see with patients with preeclampsia are increased left ventricular wall thickness, potentially right ventricular strain, left atrial enlargement. So that's just sort of what I wanted to picture there, that we are starting to gather more and more data about how preeclampsia specifically affects cardiac function. And this is just a little bit more detail about, right at the bedside there, we can calculate ejection fraction is what this is showing here. And then this is a picture of the inferior vena cava on ultrasound. I got the liver here and the right atrium that we can use to assess patients' fluid balance and potentially fluid responsiveness by looking at that. And that's a whole nother talk, point of care echo, which I'm happy to give, but for the sake of time, I'll just move on here. I think eclampsia is one of the last things that I wanted to cover. So as you know, headache and visual disturbances are reported in up to 80% of women prior to seizure, but not 100%. And elevated blood pressure, as you know, is not necessarily present or documented prior to the onset of seizure either. But nevertheless, those neurological findings may be a warning. So if a patient is found to be having a seizure, of course, the first step is to initiate basic supportive measures, airway, breathing, circulation, we call them the ABCs, and to, of course, anticipate a difficult airway for anesthesia colleagues, as pregnant women in general have difficult airways due to some physiologic changes, but this is definitely increased with conditions like preeclampsia and eclampsia. Fortunately, most seizures are self-limited, but again, magnesium sulfate with bolus and infusion is the drug of choice. And just a reminder here that when a patient is having an eclamptic seizure, we would expect to see fetal heart rate changes due to that acute event, for example, bradycardia. And other changes, but just a reminder that we would expect these to resolve once the maternal condition is stabilized. And so refractory seizures is a challenging situation that usually would involve admission to the intensive care unit, some kind of head imaging, anti-epileptic infusions. And then finally, fetal neonatal complications, of course, since preeclampsia is caused by and reflected directly in the fetal placental unit by, and usually manifested by growth restriction, low fluid levels, or oligohydramnios. And of course, preterm delivery that is usually iatrogenic on our behalf and for the behalf of the mother. In terms of delivery for preeclampsia and preeclampsia complications, it's hard to really, it's very much case dependent and gestational age dependent, but I've listed here what we consider some contraindications for pregnancy continuation in the setting of particularly preeclampsia with severe features. So at 34 weeks gestation or in a pre-viable or peri-viable gestational age, we would recommend delivery. And then you can see there I've listed the other conditions. And then cesarean delivery for preeclampsia is a case-by-case decision, again, that those conditions do not necessarily mandate a cesarean delivery. And so just to summarize, preeclampsia is the presence of hypertension with in-organ manifestations, and we've covered some of those. Complications of preeclampsia, including organ failure, may necessitate admission to the ICU, intensive care unit. And then antihypertensive therapy and magnesium sulfate, timely administration of these agents are key to addressing and avoiding some of the specific complications that we talked about.